Welcome to ECG Made Easy in 10 minutes, your comprehensive and straightforward guide meticulously designed specifically for MBBS students, medical interns, and candidates preparing for crucial exams, helping you build a solid foundation in ECG interpretation. Today, we're going to demystify electrocardiograms, commonly known as ECGs, which serve as vital, indispensable tools in everyday clinical practice for assessing heart health. An ECG precisely records the heart's electrical activity over time, delivering crucial, life-saving insights into its normal function, as well as any potential abnormalities that could indicate serious conditions. The clinical importance of ECGs is vast, spanning the diagnosis of various arrhythmias, detection of myocardial ischemia, identification of electrolyte imbalances like hyperkalemia or hypokalemia, and much more in patient management. Grasping the basics of ECG interpretation is absolutely fundamental for every aspiring and practicing medical professional to ensure accurate and timely cardiac assessments. To start our journey, let's dive right into exploring the ECG paper itself, which forms the very foundation of all ECG readings. ECG paper features a precise grid composed of small squares measuring 1 mm by 1 mm and larger squares of 5 mm by 5 mm, each representing specific standardized time and voltage measurements essential for analysis. Horizontally on the ECG paper, each small square represents exactly 0.04 seconds of time, while each large square accounts for 0.20 seconds, allowing us to measure cardiac intervals accurately. Vertically, each small square corresponds to 0.1 millivolts, and each large square to 0.5 millivolts, providing the scale needed to evaluate the amplitude of electrical deflections reliably. The standard paper speed for ECG recording is 25 millimeters per second, a critical parameter that ensures all timings are consistent and accurate for proper clinical interpretation. Additionally, the voltage calibration is standardized at 10 millimeters per millivolt, guaranteeing that amplitude readings remain consistent across all ECG machines and tracings. With the basics covered, now let's advance to the practical skill of calculating heart rate from ECG strips, a key first step in any interpretation. For regular rhythms, the simplest and most reliable method is to count the exact number of large squares between two consecutive R waves, which are the tallest peaks in the QRS complex. Once counted, divide 300 by this number. For instance, if there are 3 large squares, 300 divided by 3 equals 100 beats per minute, to swiftly obtain the heart rate. For irregular rhythms, such as atrial fibrillation, count the total number of R waves present in a standard 6-second strip, equivalent to 30 large squares wide. Then, multiply this R wave count by 10 to estimate the average heart rate. For example, 7 R waves in 6 seconds times 10 yields 70 beats per minute. Mastering accurate heart rate calculation is essential for properly assessing cardiac function and guiding immediate clinical decisions in patient care. Moving forward, our next focus is on analyzing the heart's rhythm, which tells us if the electrical activity is normal or abnormal. Sinus rhythm represents the normal, healthy heart rhythm that originates from the sinoatrial node, the heart's natural pacemaker located in the right atrium. One of its key identifying features is a consistent P wave, representing atrial depolarization, preceding every QRS complex without exception. The PR interval, measured from the start of the P wave to the start of the QRS complex, represents atrial depolarization, followed by the AV nodal delay, and it should remain consistent between 0.12 and 0.20 seconds. The QRS complexes, which indicate ventricular depolarization, should be narrow, typically less than 0.12 seconds, and uniform in shape across the strip. Finally, the regularity of RR intervals, the time between consecutive R waves, confirms the overall consistency of this normal sinus rhythm. Fully understanding these core components, P waves, PR interval, QRS, and RR, is vital for proficient rhythm analysis in clinical settings. Now, let's delve deeper into the specific intervals and durations that define a normal ECG tracing. The PR interval, extending from the initial deflection of the P wave to the beginning of the QRS complex, normally ranges from 0.12 to 0.20 seconds, or about 3 to 5 small squares. QRS duration, the time for complete ventricular depolarization, is typically brief at 0.06 to 0.10 seconds, or 1.5 to 2.5 small squares, indicating normal conduction. The QT interval encompasses from the start of the QRS complex to the end of the T wave, reflecting both ventricular depolarization and subsequent repolarization phases. Normally, the QT interval's duration adjusts with heart rate, but should generally be less than half the preceding RR interval to avoid risks like torsades de pointes. A prolonged QT interval exceeding these norms can signal a heightened risk for dangerous ventricular arrhythmias and requires urgent evaluation. Transitioning now, let's discuss the cardiac axis, which provides insight into the heart's electrical orientation. The cardiac axis is defined as the average direction of ventricular depolarization in the frontal plane, best assessed using limb leads. A normal axis deviation, typically between 30 and plus under 90 degrees, is confirmed when the QRS complex is predominantly positive in both lead I and lead AVF. Left axis deviation, often between 30 and 90 degrees, is indicated by a positive QRS in lead Y combined with a negative QRS in lead AVF, possibly due to left ventricular hypertrophy. Right axis deviation, greater than plus 90 degrees, features a negative QRS in lead Y and positive in AVF, commonly seen in right ventricular hypertrophy. Extreme axis deviation, also called northwest axis, shows negative QRS complexes in both lead I and AVF, which is rare and often pathological. Deviations in cardiac axis can point to underlying conditions like hypertrophy, conduction blocks, or pulmonary issues, warranting further investigation. Next, we'll examine critical ST segment and T wave changes, which are pivotal in detecting ischemia. ST elevation, where the ST segment rises at least 1 millimeter above the baseline in 2 or more contiguous leads, is a classic hallmark of acute ST elevation myocardial infarction requiring immediate intervention. Conversely, ST depression, a downward shift of the ST segment below baseline, often indicates subendocardial myocardial ischemia or other stressors like digoxin effect. T-wave inversion, where the normally upright T-wave flips downwards, can suggest ischemia, electrolyte disturbances, or post-infarction changes, always prompting clinical correlation. These ST and T-wave changes are absolutely critical for diagnosing acute coronary syndromes, from unstable angina to full-blown myocardial infarction. Prompt recognition and response to these ECG findings can truly be life-saving in emergency cardiac care. Now, let's review some of the most common ECG abnormalities you'll encounter in practice. Atrial fibrillation is readily identified by an irregularly irregular rhythm, absence of distinct P waves, and a chaotic fibrillatory baseline, leading to variable RR intervals. Ventricular tachycardia manifests as wide QRS complexes, greater than 0.12 seconds, that are rapid at over 100 beats per minute and occur in a regular pattern, posing a hemodynamic threat. Complete heart block, or third-degree AV block, is characterized by complete dissociation between P waves and QRS complexes, with QRS often wide and slow due to ventricular escape rhythm. All these abnormalities, atrial fibrillation, ventricular tachycardia, and complete heart block, demand immediate clinical attention and often urgent intervention. Finally, understanding myocardial infarction localization is key for targeting therapy to specific coronary arteries. Inferior myocardial infarction typically presents with ST elevation in leads 2, 3, and AVF, corresponding to occlusion of the right coronary artery affecting the inferior wall. Anterior MI is diagnosed by ST elevation in precordial leads V1 through V4, usually due to left anterior descending artery blockage impacting the front of the heart. Lateral wall MI shows ST changes in high lateral leads I, AVL, and low lateral V5, V6, often from circumflex artery involvement. Posterior MI is indirectly suggested by ST depression in anterior leads V1, V3, alongside tall R waves in V1, V2, with true posterior leads confirming elevation. Accurately localizing the MI site helps pinpoint the culprit coronary artery and guides precise revascularization strategies. To wrap up effectively, Here's a systematic, step-by-step approach to ECG interpretation that you can rely on every time. Begin with the basics. First, assess the heart rate accurately, then determine the rhythm type, followed by evaluating the cardiac axis orientation. Proceed to scrutinize the P waves for presence and morphology, measure the PR interval precisely, and check QRS duration for narrow or wide complexes. Conclude by examining the ST segment for elevation or depression, analyzing T waves for inversion or peaking, and verifying the QT interval length. This structured 9-step method ensures a thorough, consistent ECG interpretation where no critical details are ever missed in high-stakes scenarios. Remember, to achieve true mastery in ECG interpretation, commit to practicing daily with real strips and cases to sharpen your diagnostic skills.